It gives me great pleasure to introduce the seminar, Predictors of Premature and Early Natural Menopause. We have two wonderful speakers, and we are going to begin the webinar and then have questions at the end. And for our first speaker, Professor Irene Lambrinoudaki. Dr. Lambrinoudaki is Professor of Endocrinology in the Second Department of Obstetrics and Gynecology at the University of Athens. She has been responsible for educational, clinical, and research activities in the menopause clinic of the department since 2000. She has authored 256 publications in peer-reviewed international journals, mainly on gynecologic endocrinology, menopause, hormone therapy, and osteoporosis. She's president of the Hellenic Society of Climacterium and Menopause, past president of the European Menopause and Andropause Society, scientific director of EMAS, currently an editor-in-chief of the journal Maturitas, the official journal of EMAS. She is the recipient of the 2018 Henry Berger Prize, awarded by the IMS to the scientists with the most significant contribution in the field of menopause in the previous 5 years of a World Congress. And she is going to speak on predictors of premature menopause. This seminar was supported by an unrestricted educational grant from Besson's Healthcare. And Besson's Healthcare had no role in the selection of topics, selection of speakers, and they have not vetted or reviewed the content of the speakers' presentations.
First of all, I would like to thank the IMS for inviting me in this webinar. I have no financial relationship to disclose. And let's start with definitions. Menopause is the permanent cessation of menses, which results from the loss of ovarian follicular activity. The average age at menopause is about 51 years of age, and it has variation between ethnicities. For example, in South Asian populations occurs at around 48 years, while in women of European ancestry occurs around 50 years of age, and in Japanese women occurs around 52 years of age. For the majority of women, menopause will occur between 45 and 55 years of age. For some women, around 1 to 2% of general female population, menses will stop before the age of 40 years. This is called premature menopause, or a better term is premature ovarian insufficiency to denote residual ovarian activity in these women. If menopause occurs between 40 and 45 years of age, then it is termed early menopause. In some women, menopause is induced either through surgery or chemotherapy or radiotherapy. Today, we will discuss the factors which affect the age of natural menopause. We will not discuss menopause associated with chronic medical disease or iatrogenic menopause. And we will discuss mainly 4 clusters of factors: genetic factors, reproductive factors, lifestyle factors, and early life events, and social and environmental factors. Let's start with the first cluster of factors, the heritability. As we see from the multi-generational Framingham Heart Study, which is a large study encompassing 1,500 mothers and around 1,000 daughters, we see that the heritability estimate for the age of natural menopause for the whole cohort, meaning mothers and daughters, was around 50%, meaning that family history heredity determined around 50% of the inter-individual variability for the age of natural menopause. In other cross-sectional studies, which are done either in mother-daughter pairs or in twin sisters, the heritability estimate is between 0.30 and 0.70. Again, the average heredity explains about 50% of the individual variance for the age of natural menopause. When it comes to early menopause or premature ovarian insufficiency, then the link appears to be even stronger. For example, for women who have family history of early menopause, there's a six-fold increase in the odds of having themselves early menopause, and this is an adjusted risk for all other risk factors, while if women have a family history of premature ovarian insufficiency, then the link is even stronger. More specifically, if there's a sister with early menopause, then the woman has a ninefold increase of having herself early menopause, while when there is multiple relatives with early menopause, the risk appears to increase to 12-fold. Another risk factor having to do possibly with heredity is being a child of multiple pregnancies. As we see in twin registries, both in the UK and Australia, twin women who are born from multiple pregnancies have a threefold and fivefold, respectively, greater prevalence of premature menopause and early menopause. This does not have to do with monozygosity, because both monozygotic twins and dizygotic twins have the same risk. The same result was corroborated later by an analysis from my UK biobank, which showed that there was actually 50% higher risk of early menopause in women who were born from multiple pregnancies, and this was an adjusted estimate. The adjustment was made for multiple risk factors like birth weight, age at menarche, whether they have breastfed, and BMI. What could be the link between being a child of multiple pregnancies and having early menopause? One possible mechanism could be the poor intrauterine growth, which may lead to decreased peak number of follicles and subsequently early menopause. However, the fetal growth restriction so far has not been associated with restricted ovarian growth and reserve. And furthermore, there was no significant association between birth weights between twin sisters and differences at the age of menopause. So the mechanism underlying this association has yet to be revealed. Other genetic factors is harboring mutations, genetic variants. A meta-analysis of 22 genome-wide association studies with a large number of women of European ancestry has shown 17 loci which were related to the age of natural menopause. And these genes had mainly to do with DNA repair, with immune function, with hormonal regulation, and with ovarian development and function. These genetic variants had also a link with premature menopause and early menopause. The second cluster of factors affecting the age at menopause are the reproductive factors, and most importantly, the age at menarche. The Interlace Consortium, which pulled data from 9 large studies across the world, in the UK, Scandinavia, in Japan, and Australia, 50,000 women in total, showed that early menarche, as defined menarche less than 11 years of age versus menarche at 13 or later years, early menarche, therefore, was associated with a higher risk of both premature menopause, this was a stronger link, 8% higher risk, and early menopause with a 30% higher risk. The same was shown across the Atlantic in the Nurses' Health Study, 100,000 women, where the early menarche was defined as having menses start before the age of 9. Again, was shown that early menarche was associated with early menopause. And this was shown also in Chinese populations. Recently, a large meta-analysis was published in Maturitas, which analyzed 30 studies, both cohort studies and cross-sectional studies, where it was shown the opposite, that women with a later age at menarche, more than 13 years of age, had 10% lower risk of early menopause as compared to women with early age at menarche. Parity appears also to be associated with the age at natural menopause. In the Interlace Consortium, it was shown that nulliparity was associated with double the risk of premature menopause as compared to women who had children. Furthermore, if the two risk factors, early menarche and nulliparity, were combined, then there was an association with 5-fold increase of premature menopause and 2-fold increase of early menopause. The same was shown in Chinese women, namely lower parity and older age at first birth, both were associated with early menopause. Very recently, a large population study from Norway was published in a Human Reproduction Update, which showed that women with no childbirth reached menopause 1 year earlier compared to women who had children. The Nurses' Health Study conducted in the US population studied women prospectively with a baseline age between 25 and 42 years of age, and has clearly shown that parity was a protective factor against early menopause. Having children, having more than 2 children, was associated with a 20% reduction of the risk of early menopause. The same protection conferred long-term breastfeeding. Women who breastfed children more than 2 years had around 15% lower risk of having early menopause compared to women with a lesser degree of breastfeeding. The same meta-analysis I showed you earlier, I remind you there was 30 studies included, showed that 1 or more pregnancies during life decreased the risk of early menopause by around 20%. However, in all these studies, we have to take into account that there might be confounded by the effect of infertility, because women who ultimately do not have children may be infertile, may have reduced ovarian reserve, reduced MAH levels, and thus reach menopause at an earlier age. The characteristics of the menstrual cycle is another reproductive risk factor which may have to do with the age of menopause. In the Nurses' Health Study, it was shown that women with short menstrual cycles, meaning less than 25 days, or very regular cycles, especially at the younger ages, between 18 and 22 years, had a higher risk of reaching menopause earlier. However, we have to denote that these women had also lower anti-mullerian hormone levels compared to women with longer cycles. Therefore, we have to take into account that there may be a confounding with women with polycystic ovary syndrome or women using oral contraceptives. In the meta-analysis of maturitas I showed you earlier, there was a link between the use of oral contraceptives and risk of early menopause, and namely, use of OCs was associated with a later age at menopause. The third cluster of factors affecting the age of natural menopause is lifestyle. We begin with cigarette smoking because it is the most consistent association among lifestyle factors with the age of menopause. In an earlier meta-analysis of 15 studies, any history of smoking was associated with 1 year earlier of age of natural menopause. In the Nurses' Health Study, current smokers had double the risk of early menopause compared to non-smokers, and former smokers had still a residual effect. Furthermore, there was a dose-response association, namely heavy smokers who smoke more than 20 pack years have more than twice the risk for early menopause. The Interlace Consortium published a pooled analysis of 17 studies, again showed that current smokers had 100% higher risk of premature ovarian insufficiency and 80% higher risk of early menopause. Furthermore, there was a dose-response association, namely the risk was higher in women with higher intensity or longer duration of smoking, a higher cumulative dose, an earlier age at initiation, and a shorter time since quitting. All in all, it appears that the risk dissipates after 10 years of stopping smoking. What could be the link between this association? Smoking increases the production of adrenal androgens. This may blunt or resist the functions of estrogens, and furthermore, women who smoke display a faster degradation of estrogen in the hepatic metabolism, so there may be that sex hormone have a shorter half-life. In contrast to smoking, where there's a documented strong association, the association with alcohol is not that robust. In the nurses' health study, it was shown that non-drinkers had early menopause compared to social drinkers, but this association was weak. And furthermore, high consumption of alcohol was not associated with the age of menopause. So for alcohol, we cannot say that there is a definite association with the age of menopause. What about body mass index? All in all, it appears that being underweight confers a risk towards early age of menopause. In the nurses' health study, women who were underweight had the 30% higher odds of early menopause, and on the contrary, women who were overweight had a 20 to 30% lower risk of having earlier menopause. The same was shown in the analysis of the interlaced consortium. Underweight women had twofold higher risk of early menopause, even after adjustment for confounders. In an early meta-analysis of 9 studies, again, underweight women had 8% higher risk of early menopause, as opposed to overweight women with around 10% of lower risk of early menopause. Summing up the effects of body mass index, it appears that we have a more robust data about the underweight as, for the link of early menopause. Underweight women may be malnourished, may have done a weight loss diet and lost weight abruptly, or there may be concurrent underlying chronic disease, or they may over-exercise. On the other hand, the evidence is not that solid. Women who are overweight may have menopause at a later age, perhaps because of increased leptin, or perhaps because of estrogen production in their adipose tissue. The fourth clusters linking risk factors linking to the age of natural menopause are the early life events and social environmental factors. Children who are malnourished, especially during their early life, between 2 and 6 years of age, children who has low body weight at the first or the second year of their life, or children who have not breastfed, later as women may experience menopause at an earlier age. Furthermore, the cognitive function of children, of girls, appears to have a link with the age of menopause, and the evidence comes from 2 birth cohort studies in the UK, with a total amount of women of 5,000, which shows that lower cognitive scores in childhood are associated with earlier age menopause. The suggested mechanisms are that maybe ovarian steroids across life can influence both neurodevelopment and the timing of menopause. Furthermore, childhood intelligence is associated with better general health overall in adulthood. Childhood abuse may also influence the age of menopause. The evidence comes from 2 longitudinal studies, the Avon longitudinal study of parents and children, which shows that childhood sexual abuse was associated with an early age of both menarche and menopause, and a very recent study published in Menopause a couple of months before, the National Longitudinal Study of Adolescent to Adult Health, showed that mothers who were sexually abused as children and who had sexually abused children reached menopause 8 years earlier compared to mothers with no personal history of sexual abuse. Furthermore, the parental divorce or the absence of a father, especially during the early years, between 6 and 11 years of age, may again have an association with the age of menopause. Probably the effect is through increased stress, which increases the release of stress hormone, which affect the physiology of the ovaries. Summing up the early life events, it appears that the adverse socioeconomic circumstances in childhood, poor nutrition, the early emotional stress through violence or parental divorce, and low cognitive function may have an impact on the age of menopause. Furthermore, during adult life, education, occupation, and income may have an impact on the age of menopause. 22 out of 29 studies in recent systematic review showed that lower level of education is indeed associated with an earlier age of menopause. Furthermore, in a large survey in Korean women, it was shown that women with lower household income and lower education had about 50% higher risk of having premature ovarian insufficiency. Finally, the intimate partner violence, also perhaps through the stress mechanism, appears to have an effect on the age of menopause. In a large population-based Australian cohort, 6,000 midlife women, it was shown that there was indeed an increased risk of early menopause for these women who experience intimate partner violence. And this risk was there even if it was the smoking was taken into account. All in all, it appears that these effects are through stress mechanisms. Summing up, the risk factors for premature and early menopause for which we have solid evidence are genetic factors, family history of premature or early menopause, being a child of multiple pregnancy, or harboring specific genetic variants. From reproductive factors, early menarche, especially if associated with nulliparity, is a strong predictive factor, and from lifestyle factors, smoking is the most significant, followed by the underweight. Based on this data, we can make the following recommendations. The age of menopause varies across populations, so we have to consider population-specific age of menopause for decisions about the time of HRT cessation in women with premature ovarian insufficiency. Furthermore, we have to monitor for early menopause women who are at high risk for shorter reproductive lifespan, meaning women who have family history of early menopause, who are children of multiple pregnancies, or nulliparous women who experience early menarche. Furthermore, we have to provide lifestyle advice, especially we have to urge women quitting smoking, preferably at an early age, before the age of 30 years, and to maintain an optimal body weight.
Thank you so much, Dr. Lambrinoudaki. That was really terrific, a great overview. And we are going to go next into Dr. Anderson's talk. And at the end of that, we'll have questions. So it's a pleasure to introduce Dr. Anderson as well. He is Professor of Clinical Reproductive Science at the University of Edinburgh and works clinically in infertility and reproductive endocrinology. Trained in obstetrics and gynecology with subspecialization in reproductive medicine. He has always had a strong interest in reproductive endocrinology and runs a research group investigating female reproductive lifespan with laboratory and clinical aspects, particularly related to the adverse effect of cancer treatment on fertility. He's also conducted clinical studies developing our understanding of the novel neuropeptides kisspeptin and neurokinin B in human reproductive function in men and women. He is a member of the ESHRI Executive Committee and the HFEA Scientific and Clinical Advances Advisory Committee, and he will be talking about using AMH to predict early menopause. Thank you.
Well, thank you very much, Dr. Santoro, and lovely to be here at the invitation of the IMS today to discuss this interesting topic. So we've had a fantastic overview of age of menopause from Irene, our previous speaker, and I'm going to try and just focus on this one specific area today, talking not just about natural menopause, but about early and menopause and POI as well. I don't have any specifically related disclosures other than doing some work with Roche Diagnostics who make AMH assays. So let's start by reviewing a bit of AMH basic biology, just so we're all on the same page here. And this is an immunohistochemical image of a primate ovary. It's actually a monkey rather than a human ovary, but it just shows the same the features extremely nicely. And that is here in brown, you have the AMH expression in these growing follicles, in the granulosa cells of growing follicles. And so this is the key source of AMH in the bloodstream, these particularly the small antral follicles. And what's particularly valuable about AMH in the many clinical contexts in which it's become established is that it's not so much produced by the pre-ovulatory follicles here, except a little bit around the cells that go on to produce the cumulus, but by and large, the preantral follicle, so the late antral follicles related to ovulation don't produce significant AMH, nor is it produced by the corpus luteum here at the bottom. So this means that serum levels are relatively stable across the menstrual cycle in comparison with many of the other reproductive hormones we have available to measure. So this illustrates this in the same way. And the important aspect of this essentially is that AMH is not produced by the primordial follicles, and therefore it's not a direct measure of the true ovarian reserve. It's what you might call the functional ovarian reserve, particularly these antral follicles that will respond to gonadotrophin development and go on through the normal menstrual cycle to then produce the pre-ovulatory estradiol that is so fluctuant up and down across the cycle. And I think it's also worth just emphasizing that it is these smaller, but still in the larger scale of follicles, quite late advanced stages that are producing the most AMH. If you measure the amount of AMH in a follicle, the peak is around 7 or 8 millimeters. And if you analyze the amount of AMH in the bloodstream, the majority of it, some 60%, comes from follicles of about 5 to 8 millimeters diameter. So these are follicles that are just getting ready for selection for dominance, whereas the smaller follicles produce much less, and by extension, the ones you can't see on an ultrasound scan, the preantral follicles are producing very little, even though numerically they are going to be the greater ones. And of course, they are some weeks or even months away from their initial non-growing state, the primordial follicle, which is what we really want to know about in this context. So let's look at AMH levels across the menopause, and we have here in the red line the average range, the average AMH level across age, and you can see this wide divergence from one woman to the next. And the key features are this peak around the age of 24, followed by a decline through to the menopause, and obviously that's what we're going to be focusing on today. But there are a number of other interesting changes that go on through childhood that are indeed, as I say, very interesting, but less relevant today. But they do illustrate the fact that because, of course, you're born with all the primordial follicles you will have, this stage during childhood, when you have a reducing number of primordial follicles, but accelerating primordial follicle recruitment, you have this rising AMH, and then only later on do you have this very clear equal relationship between the declining AMH and the declining rate of primordial follicle recruitment, with this period in between of a late adolescence into early adulthood of this sort of reorganization of the ovary with this still rising AMH levels, but is starting to decline rate of follicle recruitment from the non-growing stage. So this really just serves to illustrate that AMH is telling us a lot about what's going on in the ovary in terms of follicle activation, but the follicles it's coming from are some distance from the true primordial follicle reserve, which is going to determine the age at menopause. So from that, you will immediately think, well, this is going to be a very interesting marker of this, of the reproductive aging. And indeed, this concept has now been around for some 20 years. In fact, this first paper from Bart Fauser's group in Rotterdam, where he was at that stage, raised this exact question of anti-Müllerian hormone being a novel marker of ovarian aging. And you can see here in the middle panel here, this is the key data from that paper, showing individual women sampled on 2 occasions with this decline in AMH over time and a progressive population decline over age, with a much tighter variability than the rather more chaotic pattern of FSH levels, although, of course, a slight trend towards upwards across this age, and a similar, slightly wider variation in follicle count over this. But you can see here again, immediately, there is always going to be this slight disparity between what's valuable on a population basis and what's individually valuable from a single patient. And you can see here that within this group, while the majority of women are showing a decline in AMH on repeated sampling, you can see that there are a couple here who are showing a steady level, if not a slight rise. So there's always going to be that slight individual variation where it compared to an overall population value in this type of analysis. So this idea was really been taken forward in a number of studies that are still ongoing in this, trying to analyze this to get the most tight result and really understand this relationship of whether AMH can be valuable in predicting age at menopause. And the first to really assess this in a fairly formal way was, I think, this study from the US, which was part of a larger metabolic study, where a group of women were followed prospectively annually over a period of 6 assessments starting in their early 40s. And you can see here in the top right how their AMH levels fell in the years towards their final period, with AMH becoming undetectable about 5 years before the final period. Now, 5 years is a long period of time, and that may reflect assay sensitivity, and we'll come back to that in just a second. But you can see that there was a very clear relationship in terms of prediction, whereas although changes in inhibin B going down and FSH going up, these were also predictors. It was the AMH that was mathematically the more accurate predictor of both time to and age at final menstrual periods. So that was a study based in 2000, or published in 2008. So using relatively early generation AMH assays. And of course, they've been largely now replaced with automatic assays from a couple of the major manufacturers. In terms of precision, they offer advantages, but they're also some 10-fold more sensitive than the previous manual ELISAs. And of course, we also have the ANCH-PICO AMH assay, which offers probably still even greater sensitivity and down to the order of individual picograms per mil of AMH that start to become detectable, even if not robustly quantifiable at that level. However, it is still the case that these assays are not standardized against each other, and there isn't an international standard. And that's perhaps particularly relevant when we're talking about right at the absolute edge of detectability with these assays. And so what's sensitive detectable in one assay may be quite different to what's going on with a different antibody panel in another assay. And that really needs further investigation, particularly, as I say, right down at the bottom of the range, which we're talking about today. So what other data do we have that support this idea that AMH will identify women likely to go through an earlier menopause? Well, there are probably a couple of other cohorts. And one is a number of analyses of a Dutch cohort that have gone on over the years, led by Frank Broekmans and colleagues. And this is a graph from their original paper in 2011, where they had some 257 ovulatory women followed up. And what they identified was that those who had the lower age-related AMH had a shift towards a lower age at menopause. whereas those who had a higher age-specific AMH showed a shift towards a higher age of menopause. And you'll note within that description of those results is the importance of an age-specific value rather than just an absolute value. And that will be a theme that I come back to on a number of occasions through this talk. They've subsequently gone on to larger analyses, largely confirmatory of this initial finding. So in this more recent meta-analysis of over 2,500 women, of over 1,000 of whom went through a menopause, you can see that they were able to quantify that the risk of going through an early menopause before the age of 45 was about 28% in those with an AMH in the bottom centile. So still, essentially, the other way of looking at that is the majority of women, even with a low AMH in the bottom 5th centile, still do not go through an early menopause. A lot of data from Iran has also come out on this, from Tehrani and colleagues, and this is actually just part of a table that they published on this. It's an enormous table that goes over 2 pages of JCM, and they highlight essentially similar findings, essentially documenting that in young women with very low AMH, there is indeed a significant risk of going through a very early menopause here. So a 20-year-old with the lowest level of AMH that they quantified had a identified or predicted age of menopause of 33 or 34 if she was just a little bit earlier. So this seems to identify women at risk of a premature or certainly an early menopause. In a more middle reproductively age group, someone in their mid-30s who's got a more average AMH level, then you can see that the value becomes less useful. So a 34-year-old with an average AMH that would predict that she would have an AMH of an age of menopause at 50, the range of that prediction goes from 41 to 55. So really not clinically terribly useful when you're still some way distant from your menopause with a reasonable level of AMH. What about repeating measurements? Does this trajectory downwards, does that help? Well, not enormously. And again, we have Dutch data that have really emphasized this. And so this is on both menopause prediction and early menopause prediction, so below 45 again. But you can see, so this is the C statistics, as the area under the curve here, essentially. And you can see in the youngest women, then you have a certain prediction, and that is improved a bit by looking at that decline rate over that 20 to 25 year age range. But when they look at slightly older women and the decline rates in these older women, 25 to 30, 30 to 35, you can see that that does not at all change the prediction. So a single value in these women over 25 was just as good as a rate of decline. And essentially the same applies both to natural age of menopause on the left and early menopause on the right. But in that same paper, they do also come up with some other, I think, really quite important caveats to what seems like a common sense interpretation. You have a lower MH, you're going to go through an early menopause. That doesn't always seem to hold. And what they highlight is what I just said, that this knowledge of decline doesn't improve prediction. But they also highlight what's shown in this graph here of a lot of the data falls below the line between expected and observed risk, i.e. there is, as well as a low discriminative ability, an underestimation of the risk of early menopause. And so they conclude that the use of AMH as a screening method for the timing of menopause cannot currently be advocated. Most recently, we've had a study from our own chair today, the SWAN study that was published now nearly 2 years ago in JCM. And this was a large study of over 1,500 women, AMH measured annually through to their final menstrual period, starting at a relatively late age, you'll note. So the average age at the first measurement was already 47.5 years. And you can see here overall, as you'd expect, this decline in AMH through to final menstrual period, but still some women with detectable AMH, albeit very low, even in the months up to a year following their final menstrual periods. And if you look at the deciles of AMH against months to FMP, you can see this very clear relationship with a rather sharper discrimination than you would get from FSH alone. And then they very nicely went on to look at the diagnostic accuracy, because this is the key thing, is what is, it's all very well showing average differences, but what is the actual diagnostic precision of this type of test? And this is a table from this, lots of very interesting analysis in this paper, looking at different time points, women of different ages across this range. But these two sentences are pulled out below, perhaps key summaries. So if you have a very low AMH, barely detectable, the probability of FMP within 12 months is about 50-50 if you're less than 48, going up to nearly 80% if you're over 51. But conversely, if your AMH is over 100, so readily detectable, then the probability of final period not being within 12 months is very, very good if you're under 48, and still 90% if you're over 51. So essentially, the ability of detectable AMH to indicate you're not likely to go through to your menopause within the next year is much more accurate than an undetectable AMH showing that you are already have an imminent menopause. What about premature menopause? Well, much of the same principles apply, in fact, as you would expect. And this is one of the earliest studies showing this decline in AMH as women progress through into premature ovarian failure, although a cross-sectional study rather than truly longitudinal. But you can see overall the decline in AMH levels with more and more women having undetectable AMH levels as they go through what they call incipient ovarian failure with a high FSH but regular cycles, through to irregular cycles with a high FSH, and then established premature ovarian failure. So this looks like a useful diagnostic test. And of course, we're familiar with many of our younger patients having quite a delayed journey to this diagnosis of premature menopause or premature ovarian insufficiency. We looked at that in my combination with my colleague Raymond Lee as a diagnostic test for women with oligoamenorrhea. And the key result is shown here, where you can see, of course, women with PCOS, type 2 anovulation, have very high AMH levels, but here, women with POI, low, but not invariably undetectable, but a very good discrimination between them and other diagnostic causes of oligoamenorrhea. So essentially, it remains not part of the official diagnosis. That may change, but I think it is going to be something that's useful in the early stages of the condition, when there often is a little bit of diagnostic uncertainty. And I'm sure we've all seen patients where, in retrospect, the diagnosis was very obvious, but for whatever reason, it was delayed. But there may be some patients with specific forms of POI, particularly autoimmune POI, where you do actually get a perhaps discordant reading with a relatively normal AMH, despite this being the actual diagnosis. So as I say, it's not part of the diagnosis at the moment, but the ESRA guideline on POI is about to start to be revised, and I'm sure that the inclusion of this will be an important part of the discussion and conclusions in this new version of this guideline that will be forthcoming in a couple of years' time. There's another specific group of patients where this might be relevant, and that's patients with a cancer diagnosis. And that was touched on previously by Irene. And we've been interested in this ourselves as to whether we can measure AMH pre-treatment as a predictor of whether the ovaries are going to fail after chemotherapy. As a diagnostic test after treatment, can you reliably show that this woman's ovaries will not recover activity, and potentially pushing that right back, not only from a period of time afterwards, but closer and closer to the end of treatment, to get a clearer view of whether some women are on this green trajectory and things will recover, or whether actually they remain below the POI threshold of activity and they will not show any further ovarian function. So some years ago, we were able to show that actually pre-treatment AMH in breast cancer is a good predictor of whether your ovaries will still be functioning and you'll be having menses 5 years later. and indeed it was a slightly better predictor than age. And you can put together a mosaic chart here of identifying AMH and age and being able to read off whether or not a patient is going to become amenorrheic or will still have menses even before treatment has started. And this again, as you'll see, highlights that this is not just purely an AMH level, it's very much in the context of age, as we've heard throughout all these bits of research that I've discussed with you today. Subsequently, we've looked at whether it's a useful diagnostic test, and indeed overall, if you look at women with POI versus not POI, some 2 years after chemotherapy for breast cancer, you can see you have a good diagnostic test. But again, age is absolutely critical here in this recovery of ovarian function after chemotherapy, with women under 40 showing a robust recovery in many cases, whereas those over 40 exposed to the same treatment really show very little recovery. And at the age of 40 seems a pretty handy rough and ready cutoff for this discrimination between the potential for recovery or not. And recently we've elaborated on that with another set of samples we were able to obtain prospectively from women with breast cancer, showing that an AMH at 30 months after treatment, you can see the big difference in FSH levels, so good diagnostic test, but even at 6 months after treatment, you still have big differences in subsequent 30-month FSH levels between this. And if you look at the diagnostic accuracy, you can see you have a very high diagnostic accuracy at 30 months using whether or not AMH is detectable or not, as to whether that woman's ovaries really have failed. But even 6 months afterwards, you still have a very respectable area under the curve of 0.86 of showing whether or not that woman's ovaries will recover if she has detectable AMH, or if her AMH is already, or if it's undetectable at 6 months, those ovaries are very unlikely to recover if she's over 40 years old at the time. So in conclusion, I hope I've shown you that AMH, I think, is the best marker we currently have of the ovarian reserve, but there are reservations here. It is not a marker of the true ovarian reserve, and there is quite a time discordance between the primordial follicle and those follicular stages that are producing the AMH that we measure in the bloodstream. It's clearly of diagnostic value in identifying women whose ovaries have gone through POI or a natural menopause, but I think there remains still work to be done in how it might be used in adding to the current diagnosis of menopause, and whether the current diagnosis of 12 months of amenorrhea really is clinically perhaps burdensome, and it might be substantially added to by the measure of AMH, particularly with these new highly sensitive assays. Prediction is always more important, is never easy in any form of life. And I think it's also really important here to remember that every part of the data I've shown you today, age is also an important covariate of interpreting that AMH level. And I hope I've also shown you that AMH is much better at excluding imminent final menstrual period, imminent menopause, than actually identifying and predicting it. So it has value, but other than in the imminent stage of the situation, confidence intervals are actually fairly wide. So thank you very much for your attention, and I'll be very pleased to join in some discussion.
Well, I want to thank our speakers for really excellent overviews. It kind of reminds me of that famous phrase of Yogi Berra, it's hard to predict, especially about the future.
Yeah.
So we have some questions appearing rapidly in the Q&A. Dr. Pinas asks, thank you for this excellent overview. Would you advise adhering to the 10-year window of opportunity in women with early menopause using transdermal hormone therapy? I don't know if you want to take that one, Dr. Lambrin.
Yes, of course. So if I understand correct, the answer is if a woman has experienced early menopause or premature ovarian insufficiency and she hasn't taken hormones for 10 years, then are we allowed to prescribe transdermal estrogens? Is that correct?
Yeah, and I think the question was really how long, is 10 years a good idea to continue hormones, or do you continue up to the age of natural menopause?
Well, it is advocated to continue to the age of natural menopause, but of course, this is a personalized decision. that has to be shared between the patient and the physician. If the woman wants or has indications to continue over for more than the 50 years of age, then she's eligible to continue. There is no time limit, I think. But again, if I think that the question was if the woman starts late after the last menstrual period, if some years have passed between her last menstrual period and the time that we want to start HRT, if we are allowed to start, or her cardiovascular system will not be that fit anymore. So my position is that if we estimate the cardiovascular risk of the particular woman, and she's low to moderate cardiovascular risk, we may commence HRT, preferably transdermal HRT, independently of the chronological time that has passed between her own final menstrual period and the time we want to commence HRT.
Thank you. We have an anonymous attendee who has asked, please call this condition by its proper name, premature ovarian insufficiency.
I fully agree. Okay.
Much easier for young women to come to terms. Yeah, I mean, we've gotten a little confusion because there's primary ovarian insufficiency is also out there. And, you know, I think that does get a little confusing. It would be nice to have one term.
I'm not sure we're going to get there, to be honest, Nanette, just yet, because I think there's quite a significant transatlantic divide on that. Yeah, so I think within Europe, premature ovarian insufficiency is now really very well established, and I was a member of the ESRA guideline group that we helped promote that, and I think that was a really great piece of work that did promote that. We do have some disagreement from your side of the Atlantic, I'm afraid, on whether it really ought to be primary. So to my mind, you know, the reason why I think it's very clear what the right answer here is that you know, in the issue in premature ovarian insufficiency is the prematurity, because otherwise primary ovarian insufficiency is something that happens to all ovaries, and so it's the prematurity that's what's important in this particular aspect.
Yeah, I agree.
Good.
There's only so much I can do on this side of the pond, you know.
Well, it's glad that we have allies on that side as well.
And Dr. Naftalin asks, since rodents go through ovarian failure long after they stop cycling, can they be used in studies on menopause?
Well, should I try and answer that? Excellent question, Fred. Thank you. So that's. I think it depends very much on what you're trying to ask. When you need to use the relevant model for the relevant question, isn't it? And I think if you're trying to identify of what's going on in terms of ovarian function and where AMH is produced and what its actual functions are within the ovary, then yes, rodent models have their values. But in terms of these larger epidemiological studies, then we have to go to human studies to do them.
Dr. Juniku asks, great lecture, wanted to ask about patients using oral contraceptives who are sort of around 40 to 45. Is there an appropriate time to measure AMH?
Yeah, thank you. That's interesting. So taking hormonal contraception, particularly the combined pill, does reduce AMH levels on average by about 30% or so. So it doesn't switch it off, but it does reduce it a bit. How long it takes to recover from that is perhaps been less well studied. But I think that what it essentially means is if you have a patient who you think is menopausal, who is taking the combined pill, and you want to try and use AMH to establish that, if she has a readily detectable AMH, then she is not menopausal. If she has an undetectable AMH, then you really don't know, and then you might want to stop it and see what happens and repeat it.
Yeah, I would agree with that. I think, you know, again, it speaks to AMH being better at excluding menopause than it is as ruling it in. And Dr. Ball asks, we see many women at all ages of menopause more than 12 months from their last menstrual period, and they start cycling again after starting hormone therapy. This can cause confusion. They get investigated as postmenopausal bleeding. But doesn't it make logical sense that improving general well-being and improved lifestyle with hormone therapy maybe reinvigorates the ovaries? So I wonder if either of you have any comments on whether you think hormone therapy may be reinvigorating the ovaries, or is this just a statistical happening that happens to women?
Well, shall I answer this?
Irene, please do.
Okay, so when we commence HRT, post-menopause, very usual we get bleeding. This is usual and does not warrant the investigation for post-menopausal bleeding, at least for the first 3 to 6 months of commencing HRT. Of course, if the bleeding persists over 6 months of duration, continuous duration, then we have to investigate. But we also can commence cyclical HRT, which produces monthly bleeds, and in this way, if the woman is very close to her last menstrual bleeding, this will not cause problems. So in general, these women should not be investigated for postmenopausal bleeding, at least at the first months of commencing HRT. I think I've answered this question. I don't know if there's anything more to add.
Yeah, and I think in the absence of a denominator, you don't know how many women you're really looking at, of the total pool of women who are just going to have another period after they start hormone therapy. After 12 months of observed amenorrhea, it's about 15% of women. So it's going to happen. Dr. Naftalin asks also, there's 2 periods during which the ovary stock of primordial follicles change: during organogenesis, when OSA precursors retreat into the yolk sac and then return to the ovary, and during fetal life. How do these periods play roles in the timing of menopause?
I try and answer that. So yes, the oocyte, the primordial follicle pool, is clearly established during fetal life, and I think that some of the epidemiological data that Irene showed is very interesting in trying to give us further insights into this, talking about twin pregnancy being a risk factor, for example, intrauterine growth retardation. So essentially, fetal health being an important determinant of age of menopause. And of course, I'm sure there are going to be a wealth of other aspects that impact on ovarian development during that stage that we will start to answer further over the years to come, as to how other environmental impacts, environmental chemicals even, impact on that, and then subsequent reproductive function across the lifespan. So certainly, the bigger pool of follicles you set down, and the healthier they are, then that's likely to have an impact. But there's so many aspects of that where we really have barely the beginnings of an understanding.
And we have a couple of questions more specific to AMH measurement itself. One is, are there major confounders? And another is, are there going to be better predictors of menopause in the future? So I don't know if you want to tackle that one, Dr. Anderson.
Yeah, so are there going to be? I very much hope so. It would be, we lived with measuring FSH and the limitations of that for many years, and then Inhibin B sort of came and went relatively briefly. I suspect it was just slightly unfortunate timing, that it could have been a better measure if it had been a more easy hormone to assay. And now we have AMH as becoming the closest thing to something that's produced by the primordial follicle pool. But there will be better measures coming around. I mean, if we look at other diagnostics in our field of looking at fetal-free DNA in maternal circulation to diagnose aneuploidies and other things. And that was unthinkable even a few years ago. So the opportunity to measure something that reflects changes in the primordial follicle pool, or the activation of those, is certainly well within the realms of imaginability, even if not achievability at the moment.
Yeah, and I think we are doing the best we can with the markers that we have, because they are not direct. And there's nothing, we know so little about what the primordial follicle produces that it's hard to measure. So I don't think that cranking the current measurements to even greater sensitivity is going to get us there.
I'm sure it'll help, because we've moved from 5 years down to perhaps a few months or a year or so, as your data show, and so it may be that another knocking a decimal point off might move it a bit further, but it's still going to be an indirect measure.
Yeah, because as you showed in the graph, there are these vexing women who still have a little AMH after their final menstrual period. Now, who are they? It kind of leads into Dr. Kiesel's question, are there confounders of AMH measurement? And of course there are, we know some of them. Some women with autoimmune diseases will have a spuriously high AMH, so you really do have to interpret it in clinical context. And I don't know if you have other clinical circumstances that you've seen AMH measurements confounded. I'm going to ask the speakers.
Yeah, I think the answer there is, as you said, this autoimmune POI, you can get some strange results. I mean, I don't think it's an incorrect measurement. I think it just gives us, we just need to think very differently about where the AMH is coming from and what the cells are which cell types are being attacked by the autoimmune process to understand that. So I don't think there are a lot of factors that directly interfere in the assay. But I think it's still very much the case that this right at the bottom of the assay here, that different antibodies will perhaps pick up different isoforms of AMH, and our understanding of that is perhaps not what it could be.
And Dr. Wolfman asks if AMH is predictive of fertility in women on long-term oral contraceptive use.
So I guess there's an easy two-letter answer to that, and I think the answer is that it isn't predictive of fertility in any woman, whether she's taking the combined pill or not. There's lots of very nice studies showing that women with low, medium, or high AMH are just as likely to conceive over a period of time, independent of their AMH results. So it's not a predictor of fertility in the medium term.
And Dr. King's question, I think this is for you, Dr. Lambrinoudaki. What is the role of recreational drug use, particularly opioids, on age of menopause?
Whereas there is no solid data on this associations. However, we have to take into account that women who do regularly use recreational drugs have also risk factors for early menopause, like heavy smoking or stressor factor. So this association is not clear-cut to draw a firm conclusion.
Yeah, we had a small sample of women that we looked at, several hundred in the Bronx. Mm-hmm. And opioid use did look like they were markers of early menopause, lower inhibin B, things like that, but we didn't get an opportunity to follow them out to their final menstrual period, but it looked like they had lower ovarian reserve.
And was that independent of effects on gonadotropin in it, do you think?
They also had lower gonadotropins,
yeah.
So it's possible. They weren't terribly suppressed, but they did differ. So it's possible that that is related. We have a question for Dr. Lambrinoudaki. I imagine you refer to ovarian endometriosis, or do other locations of endometriosis affect menopause through a different mechanism?
Well, endometriosis is a risk factor for early menopause for both women who are operated upon and for women who are not operated. So we have to take into account the history of endometriosis when assessing the risk of a woman for early menopause.
And then we have another question from Dr. Naftalin. Since hormones are used for symptoms during the premenopausal period, does this affect the timing of menopause?
Sorry, can you repeat the question?
Well, because we sometimes will use hormone therapy for perimenopausal symptoms in women. Is there any evidence that that affects the timing of the age at menopause?
No. Well, hormone therapy is used for management of menopausal symptoms, but it does not affect the natural age of menopause.
And we have two questions from Dr. Navani. Is low cardiovascular risk or moderate risk based on Q risk scores? Is there any level above which you would not consider hormone therapy?
Well, women at high risk or very high risk of cardiovascular disease are not considered for hormone therapy, but I have to comment that these internet-based scores do not account for all cardiovascular risk factors. For example, obesity usually is not accounted for in this calculators. So we have to make an individualized risk assessment when we want to commence HRT.
And Dr. Navani also laments that why are AMH investigations so expensive? It's not readily available in the NHS, and it's done only by fertility specialists.
Yeah, I think that's going to change. I absolutely agree. It's lamentably expensive and restricted. I suspect that it really requires robust demonstration of the value of measuring the hormone, because I think at the moment it's you know, perhaps one of the things we discussed today is showing that it's very easy to overinterpret, and you know, lots of people want to know what it is, and then they think, oh well, what's that actually mean? Whereas in IVF, it's a very clear predictor of ovarian response. There's an established value of it. I think in other situations, it really needs to show established value, and then it will become, you can then make a case to your biochemistry department that they really need to provide the service.
And another question is social freezing of oocytes an option for young women with low AMH who would like to have a pregnancy at a later age?
Yeah, I think that's really more of a medical indication than social freezing, isn't it? If you feel that you have a patient or an individual who's at risk of POI or you know, losing her fertility at an early age, then and she has a very low AMH, then that would indeed perhaps be an indication. I think the difficulty there, of course, is the likelihood of you obtaining a small number of oocytes is going to be the limiting factor there in that situation. But certainly, yeah, yes, that's been widely used, and particularly when there's a family history of POI or the patient has other autoimmune diseases that you think might then develop autoimmune POI. Yeah, absolutely. This is an important consideration.
And I would say that there's a bit of a fine line of clinical judgment here as well, because in the States, there's some practices that I would call predatory, that kind of, you know, entice young women to do these measurements and then give them an index that kind of drives them into a panic and may drive them prematurely to be freezing oocytes. But if you do know someone has a very low AMH, the younger the better, because that's going to impact, again, the yield of eggs that you're going to get.
Yeah, I agree in it. I mean, it is, of course, the old joke, isn't it? Half the world will have an AMH level below average.
Right. And everyone, and, you know, in America, no one can be below average.
Yeah, exactly.
It's not acceptable. We have a question, is AMH influenced by fasting or low? Is it low in eating disorders or anorexia nervosa?
Yeah, so it's not influenced by fasting per se. I think that's fairly clear. But the question about eating disorders, anorexia, hypogonadotrophic hypergonadism, essentially, is slightly challenging, because on average, patients with hypogonadal amenorrhea, hypothalamic amenorrhea, do not show a markedly low AMH, but some of them will. And so particularly where you have a very suppressed gonadotrophin levels, really down to in your boots for a long period of time, then AMH can be low. So conditions such as Kalman syndrome, for example, where you have a really pronounced deficiency of gonadotrophins, then your AMH level can be low. And those women, if they are needing ovarian stimulation, it may take some time for things to get going.
And we have a question from Dr. Raphael. Are there any data on DNA methylation age? This would be epigenetic aging as a predictor of menopause.
Well, so far, there's no solid data on this.
Yeah, it's a great question. At the Society for Reproductive Investigation, we did see one presentation. I think the group was from Chicago that looked at, I think, granulosa cell epigenetic markers of aging. And they did seem to correlate with either AMH or other measures of ovarian reserve. So the jury is out on that.
It chimes in, I think, with what you mentioned, Irene, about the really exciting data that's emerging on DNA damage and repair as a predictor, isn't it? So it's all part of this whole process of these fundamental cellular pathways that determine health and how long these eggs are going to live.
And Dr. Goldstein has a comment on the question about bleeding or spotting on continuous combined hormone therapy. And he just reports that it's up to 21 to 26% in the first 4 months, but it's still 9% by 12 months. So the question of when and how to evaluate women who bleed on hormone therapy is really not resolved. And 6 months is one cutoff. Dr. Goldstein says he uses 4 months, but individualization and looking for comorbidities is part of that.
Okay, I agree.
We have an anonymous question. Does the age of detection of polycystic ovarian syndrome and the duration of the disease have any role in predicting premature menopause in later life?
Well, the polycystic ovary syndrome poses difficulties because it is associated with a higher level of AMH and at the same time with cycle disturbances. Usually, of course, PCOS gets better over time, and after women have children, then the cycles usually become regular. So I wouldn't associate the polycystic ovary syndrome with the age of menopause. Very frequently, women who still have irregular menses after 45 years of age have difficulty diagnosing menopause because irregular cycles could be mixed with the age of menopause due to PCOS. But in association studies, there is no link between PCOS and the age of menopause.
Thank you. And we have another question on how long should women stop oral contraceptives if you want to get an accurate AMH measurement? And does this vary by age?
Yeah, that's an interesting question, I think. And then I'm not aware of any study that's actually tried to investigate that. But I suspect it's actually not very long. Probably 2 or 3 months is probably adequate to give you a value. It depends how precisely you want to get and how you're going to use this information. But to show that a woman has a robustly, an AMH robustly within the normal range, if it's absent after when you stop the pill, it's probably going to remain extremely low no matter how long you leave it. So even measuring it on the pill, as we discussed earlier, is going to give you a good starting point for where you'd go from there.
Yeah, this has personal significance for me because my daughter's age cohort all became panicked by a lecture that they got in medical school about ovarian reserve, and they all began to worry, and many of them were on oral contraceptives. So I arbitrarily chose 8 weeks. So that's probably enough time to sort of flush if you think about, the time it takes for follicles to get recruited, that you'd get a reasonable measurement. But, if that's going to drive a clinical decision, I think you want to make sure that you've got enough time.
Yeah. And of course, what's going to happen then is you're going to have some unwanted pregnancies, and that's an even worse scenario if people stop using reliable contraception.
And we have a question from Dr. Lee. To our disappointment, AMH is not precise enough to confirm menopause, but can it be useful in predicting loss of fertility at the end of reproductive years, for example, advising women on ceasing contraception?
Thanks, Raymond. I think if you're already disappointed with AMH as a predictor of menopause, you're going to find it even worse at that, would be my guess, actually. Bearing in mind what we've already said about the limitations of AMH as a predictor of fertility. If you're talking about natural fertility, then of course that's about ovulation, and that's really not much to do with AMH levels.
Yeah, that is a vexing problem. And as we have seen in the SWAN study, we see cycles that appear ovulatory right up to the end of a woman's reproductive life. That tells us nothing about oocyte quality, but hormonally, it indicates that there's possible ability to become pregnant. So this about wraps up the time that we've had. I want to thank our speakers for really outstanding presentations, and really thank the audience for your tremendous engagement and really terrific questions. So thanks again, and good afternoon.